we go. Okay. So I'm Dr. Halasa. I'm the founder of Chronic Disease Prevention and Management Centers. We're going to talk about oxytocin and the use of oxytocin in managing chronic disease across all medical specialties. And we can start by watching a very interesting interview with a doctor. It was very interesting observation that she had. And she has an interview with about oxytocin. So I like to watch, and we like to watch it. And then after that, we can go ahead and continue with our presentation.
Well, thank you so much for joining me today.
Hey, Dr. Halasa, we're having a little trouble seeing your video. I think maybe if you make the screen smaller, it'll take less internet bandwidth and maybe it'll come through better.
Oh,
You know what? No, wait, the sound is muted. See, the sound is muted. So start it back over again.
Okay, let me start it over, okay?
There you go.
What about now?
Let's see if we hear it.
Can you hear it now?
I don't know yet. Hold on.
Oh, I think I need to do something. Okay.
No, we don't. That was the first step.
Yeah, I think I need to do something here. Just to bear with me right now. I know what is going on. Okay, so I need to click on the sound, share the sound, and optimize the video, and then do the sharing. And this will work. Okay, what about now? Can you see it?
Well, we got it. That's good. It worked.
Okay.
Well, thank you so much for joining me today. So my first question is, can you just give a quick synopsis about your pilot clinical study regarding oxytocin and skin aging? And also, can you kind of divulge into a little bit about your findings as well?
Sure. Well, thank you for having me. Well, I was a little curious about oxytocin and how, as you said, it affects skin aging, and I wanted to delve into that a little bit. I was really happy to find that there's been some bench work showing that oxytocin is affecting the skin, and I was very surprised to find that the skin actually produces oxytocin. There was a study showing that when the skin is caressed, that it does release oxytocin. Other studies show that it does bind receptors in the skin, and then what it does is it turns off the senescence-associated secretory phenotype, SASP. So what SASP does normally is it will secrete interleukins, IL-1, IL-6, other proteases, and this creates kind of a low-level inflammatory or a little bit of a destructive picture for the skin and causes our aging. But oxytocin, when it's present, turns this off. So it has more of a protective effect for the skin, and in effect keeps it healthier and actually looking better. So what I wanted to do is see, does this translate clinically? Can we see this in people? And so I took a small group of patients, six women, and I did some photography with a Canfield system and had everything standardized. We also used a skin age score that had been previously published, and that made it very easy to quantify and look at how well or healthy their skin is for their age. The nice thing about the skin age score is that it correlates with your age. So if you're 50, you should score about a 50. If you score 40, that means you're looking very good for your age. And vice versa, if you score a 60, then you're looking older for your age. So it was a nice tool to use. I also questioned them on their lifetime sun exposure, because as we all know, that the sun also contributes to skin aging. And they were kind enough to.
Oops.
can we see this in people? And so I took a small group of patients, six women, and I did some photography with a Canfield system and had everything standardized. We also used a skin age score that had been previously published, and that made it very easy to quantify and look at how well or healthy their skin is for their age. The nice thing about the skin age score is that it correlates with your age. So if you're 50, you should score about a 50. If you score 40, that means you're looking very good for your age. And vice versa, if you score a 60, then you're looking older for your age. So it was a nice tool to use. I also questioned them on their lifetime sun exposure, because as we all know, that the sun also contributes to skin aging. And they were kind enough to collect their urine for 24 hours, because that's how we had to measure the oxytocin. So when we got all this information together, I was just amazed to find that there was a correlation, a linear correlation between the level of oxytocin and the amount that their score, their SAS score, decreased. So in effect, the better they looked, they had a higher oxytocin score in spite of sun exposure. So one lady in my study, she had the highest oxytocin level, but she also had one of the highest sun lifetime exposure scores. But she looked the best for her age relatively. So it was very interesting. And then I also had a patient where her skin looked not as good for her age. And she actually reported a very low level of lifetime sun exposure, and her oxytocin level was low. So it just came together beautifully.
That's awesome to hear and very interesting. So we kind of touched on this a little bit beforehand, but what sparked this idea to conduct a study on oxytocin and skin aging?
So I've been in practice almost 20 years, and I've gotten to know a lot of my patients very well. Most of them are women, and we like to chit chat. And they tell me a little bit about their lives, and it's just struck me over the years how people who find a new love, or they're in love, they just have this glow, right? We talk about the glow, and they just look radiant. And vice versa. Unfortunately, I've had patients where maybe a spouse has died, or they have a long-term relationship that broke up, and they're just devastated, and the life just seems to disappear out of their skin. They just really look, not as vibrant. They look maybe more dull, and just their skin almost looks depleted, if you will. And so I got to thinking about this, because we all associate oxytocin as the love hormone, right? So the love hormone, and we know that it's released during intercourse. We know it's involved in birthing. But this is kind of a new idea of, is it involved in other things, and looking at it in the skin. So I was pleasantly surprised, as I mentioned earlier, to find that oxytocin is involved in the skin. And I dug a little bit deeper into that, because I thought, well, why do we have this in our body? Why would the body be reacting to a social situation, a physical situation, to make us look better, to make us look healthier? Well, I figured it has to go beyond that, and it does. There is preliminary research in every system of the body showing that oxytocin has a positive effect. For instance, in the GI tract, they are finding that oxytocin levels affect your sensation of being full. It's related to your appetite, and that lower oxytocin levels are correlated with obesity. So that's just one example. And so I find that this whole system is almost undiscovered, and that we are supposed to be more social with each other.
And on that, what was one of the most interesting things that you found out through the study?
So that is probably the most interesting, I feel. I mean, as a dermatologist, and in practice for so long, obviously I know about the skin. I was unaware of oxytocin's role in the skin, and I found that was fantastic. But this whole social interaction system, so I coined it the oxytocin social exchange system, because the more that we interact with one another on a physical level, the healthier we are. And it's almost this positive feedback loop that we really haven't been paying attention to. And all of these years, we've known that, getting a hug from someone will make you feel good. It'll calm you down. Some people have shown that it will decrease your blood pressure temporarily or your heart rate. But I think we were unaware how much further it goes, and it really has to do with our well-being physically and mentally. We need to really take time out of these busy modern lives that we have, and we need to find time for love and endearment. And if you don't have anyone to hug, you hug a dog. I mean, that has been shown to help, or get a massage, because stroking the skin does release oxytocin. So there are so many things that we can do to make ourselves feel better and be healthier.
Absolutely. And, my one last question I have here is, what kind of impact do you think this kind of research will have on the dermatology and like skincare beauty industry?
So I'm working with a pharmaceutical company looking at a botanical that mimics that oxytocin-like effect in the skin. And to date, it has been fantastic. The results are better than I expected. I'm very excited. So I think this has been almost a missing part of our skincare routine. But on a day-to-day level, I think that dermatologists, and even just any kind of doctor, when we see our patients, we need to remind them to, get off devices and interact with their friends and family and loved ones, because it's just so important for us. And I think this past year has really shown, a lot of people have been very isolated, and it's just not healthy for us, not just mentally, but physically. We need that interaction. That's what we're here for.
So I think that explain the need of oxytocin. She's trying to do a supplement that mimics oxytocin, but really we can even provide it through the dermal. We know there's vaginal gel for it already being done by the compounding pharmacy. And none of the compounding pharmacies have done anything topical for the skin. And it's
certainly possible. Yeah, it's
yeah,
certainly
it's only nine amino acids, so I don't think it's a big deal to put it topical and maybe add some enhancement of delivery there. I don't think that, and you will be the first, because the only thing that's compounding pharmacy did is intravaginal for dryness of the vagina and helping to manage any pain during intercourse. But I think Dr. Mike Beamer, if you start doing it in the cream, and it's only 9 amino acids with some enhancers that helps to break the keratin. And for you as a clinician, if you're doing PRP or you're doing PNP, which is platelet nanoparticle that Dr. Patel and others and Dr. Joseph James, then they can load oxytocin, and then you can do the micro needling of the face with platelets and oxytocin. That would be a great thing. Along with NAC and acetylcysteine, I like the sulfur, the thiols in the mix there. So you have all the combination. And oxytocin does stimulate the release of nitric oxide, by the way. So it's a nitric oxide enhancer to release the nitric oxide, improve the mitochondrial function as well. And just by knowing that oxytocin is inhibiting interleukin 6, and it's inhibiting NOx enzyme, which is the NADH oxidase enzyme, right? This is enough for us to be using it to manage all chronic disease across all medical specialties. Just by knowing it's inhibiting 2 things. It's an immunomodulator by inhibiting the interleukin 6, the Th17 polarization, the M17 polarization, right? And the neutrophilia. And and also it's buffering the redox and modulating the redox by inhibiting the NOx enzyme, which is NADH oxidase enzyme. Just knowing that it's inhibiting these two pieces, which is the pillar to manage chronic disease is to restore the metabolic balance and then modulating the immune and the redox. And we can see it's very clear that oxytocin does the three things. It does help to modulate the metabolic by inhibiting the excess of cortisol, and it also inhibiting the sympathetic overactivities and balanced autonomic nervous system, and possibly it enhanced the sex hormone activities as well. So that's the metabolic part. And then its immune part is by inhibiting the Th17 and M17 and interleukin 6. And then you have the redox part of it, which is buffering the redox by inhibiting the NOx enzyme. This will justify using oxytocin to manage all chronic disease across all medical specialties, including cancer, pain, degenerative disease, autoimmune disease, allergies, chronic inflammation, metabolic disease, hypertension, diabetes. So name it. All this pathology of chronic diseases, we can justify an oxytocin, including anti-aging as well. We can justify using oxytocin as a drug of choice to manage chronic disease in general. So it has an anti-inflammatory effect, and we explain why. It inhibits interleukin 6. It also it inhibits the NFK beta as well, and it has an antioxidant effect by inhibiting the NOx enzyme, but also by stimulating the expression of the epigenetics of the antioxidants and genetics of the anti-inflammatory. So it works in genetic level, epigenetic level, right? Not just blocking things, but also chemically, but also it works in the machinery of the expression of those anti-inflammatory and antioxidants. So it gives you that long-term effect. Although it's a short-term lifespan, but the effect is going to be long-term, and the reason because it changed the genetic expression, and that gives that long-term effect of the oxytocin. Although it has a short lifespan in our body, maybe a few minutes or few seconds, it easily can be recycled. They're trying to make a long-lasting oxytocin, synthetic one, but just a short acting will work because, as I said, it changed the epigenetics, and that gives its effect to be long acting. And so, they took two mice and they inject one mouse with lipopolysaccharide, another one with lipopolysaccharide. So two mice, they inject them with lipopolysaccharide, bacterial liposaccharides. And one group of mice, they inject oxytocin, the other one without oxytocin. And then they find out the one without being protected by the oxytocin, they die earlier than the mice they've been injected with oxytocin, because oxytocin has anti-inflammatory, so it's counter-affecting the lipopolysaccharides inflammatory effect. And even they do cross sections of the lung, and they see that it preserves its integrity. It's still the process of inflammation and the damaging and the fibrosis versus the one without with the group without the oxytocin, and that shows that this is very good in managing infectious disease, whether it's acute or chronic, especially with COVID. Add to that, I mean, it's inhibiting interleukin 6, which we know that the pathophysiology of COVID is hyperinflammation from the Th17 interleukin 6 mediated inflammation, right? Immune response. And because of it, oxytocin specifically inhibit hyperinflammation, and also it does increase the vagus activities. All of this anti-inflammatory effect does help in managing COVID-19. We're going to see that. So oxytocin is a potential adjuvant against COVID infection. Why? Because of its antioxidant, it's anti-inflammatory, it's inhibiting interleukin 6. We know that the pathophysiology of COVID-19 is all about the spike protein, which blocks the ACE2. When you block the ACE2, you're allowing the angiotensin type 1 receptor signaling overactive, which leads to sympathetic overactivities, but also it leads to polarization of the immune system to Th17, and M17, which leads to overproduction of interleukin 6 and neutrophilia and the damage that's caused by the COVID-19. So I think oxytocin does inhibit that hyperinflammation, the interleukin 6 immune mediated immune response. So I think it's a good thing to be used during infection. Now, can we use it for preventing COVID-19? Yes, not just COVID-19, but all the infectious disease we can use oxytocin. Why? One of the reasons because it stimulates the vagus nerve and also it stimulates the mucus production, the nasal mucus production, the oral mucosa, the tears of the eyes, and all those secretions from the eye, from the mouth, from the nose, those mucus, saliva, those tears. It helps to defend against the virus, right? That's how we defend. They interact with the viruses and they neutralize the virus just by enhancing the secretion of the tears and the salivary gland and the lacrimal glands and the nasal mucosa secretion. The secretion of this mucopolysaccharide that we have, it's very protective. It sticks to the virus and preventing the virus from attacking the cells of interest. In addition to that, we find that oxytocin doesn't have the entry of the COVID. They say it's blocked the interaction of the spike to the ACE2, same like methylene blue and ivermectin. But also it blocks the serine protease. We know the serine protease is the enzyme that's very critical to prime the spike protein. And spike protein by itself from the virus cannot attach to the ACE2 unless it's being primed, cleaved, and split by the protease enzyme. So we see that another way of that oxytocin inhibit COVID is infection is by suppressing the serine protease enzyme, whether directly or by inhibiting its expression epigenetically. And when we inhibit interleukin 6 and Th17 polarization, what would happen to the immune system? It polarizes into Th1 automatically because that's how you defend the virus is by polarization into Th1 and cytotoxic T cells. Well, because the spike protein is blocking the ACE2, is causing that polarization away from Th1. And so if you block that Th17, then automatically your body will start resuming the polarization into cytotoxic T lymphocytes and Th1. And also oxytocin increases the proliferation and differentiation of the bone marrow. So it helps to release those white blood cells into the blood. And that will definitely help to increase the lymphocytes and the attack against the invaders or the pathogens. Are you adding the people, Dr. Mike Beamer?
I am Dr. Halasa.
Yeah, please add people because they are on the list there. As much as you can help me up here. Okay, so let's go and see the next slide here. Okay, so we said that oxytocin, because it inhibits the NOx enzyme, the NADH oxidase enzyme, it buffers the redox, and because it inhibits interleukin 6, right? This is enough to justify the use of oxytocin to manage autoimmune diseases across all medical specialties. Okay, and autoimmune diseases that's being triggered by the COVID. We know the COVID-19. It makes autoimmune diseases that subclinic to become clinic, or the clinical autoimmune diseases become worse, or it trigger the autoimmune diseases itself and become on the surface and become clinical. And instead of having autoimmune diseases at the age of 70, they start having at the age of 30, for example, due to the COVID. But the oxytocin, because it inhibits the interleukin 6 and Th17, we know that the Th17 and interleukin 6, it's part of the pathophysiology of all autoimmune diseases. Before, we know that autoimmune diseases is either Th1 dominant or Th2 dominant. But then we find out that Th17 mediated inflammation, it's part of the Th1 autoimmune diseases. So let's say if I have rheumatoid arthritis, before we classified rheumatoid arthritis as Th1 dominant autoimmune diseases, but now we see there's a mix of Th1 and Th17. So rheumatoid arthritis is not just Th1,
It's also Th17. Even allergies and Th2 dominant autoimmune disease like systemic lupus, erythematosus, there is some Th17 components to it. So there is Th2, yes, dominance, and you have a lot of interleukin 4, but also you have a lot of interleukin 6. And knowing that anything that inhibits the Th17 will help both sides, will help the Th1, the rheumatoid arthritis, which is Th1 dominant autoimmune diseases, and also the Th2 dominant autoimmune disease. It will have both sides because you are inhibiting the common thing that causes inflammation between both of them, which is Th17. And so I can use it for autoimmune diseases across all medical specialties, whether it's Th1 dominant or Th2 dominant, because we know that the Th17 is part of their pathophysiology. And we see here that the reason why it is explaining it, it suppressed the upregulation of even TAL4 receptor, which is responsible for turning those macrophages into inflamed, or another word, polarizing them and turning into M1 and M17. It suppressed the release of interleukin 6. That's very critical, even for tumor, for cancer. What we need in cancer is to inhibit Th17 and polarization to allow the immune system to polarize the Th1 and cytotoxic T cells. So suppressing interleukin 6 is part of managing cancer because you don't want too much of interleukin 6 in cancer. This will move the immune system away from Th1 and cytotoxic T cells, which is very important to kill cancer. So anything inhibiting interleukin 6, it's good for cancer as well. So it suppressed the release of interleukin 6. It suppressed the tumor necrotic necrosis factor alpha, which is very important as well, and decreasing inflammation. It inhibit the nuclear factor kappa light chain enhancer of activated B cells. It increased the FOXP3, which is it increased the T regulatory cells, which is very important when you want to manage any autoimmune diseases. Or chronic inflammation. Is good to increase the Tregs, right? Because the Tregs suppress all the effector cells, whether it's Th17 or Th1 or Th2. So increasing the Treg, it's part of managing autoimmune diseases. It's not good for cancer, by the way. You don't want Tregs to be suppressed when you are treating cancer. But here's the thing. It could be the response of oxytocin on the cancer. It's different from normal tissue. Most of the time, we have to know that it could be the opposite here. So it's good for cancer, but also it's good for managing autoimmune diseases. And possibly the Tregs that the oxytocin is not that significant when they are in the cancer arena versus when we are managing autoimmune diseases. So it modulates the neutrophil. Well, if you inhibit the interleukin 6, you decrease the neutrophilia, and definitely it helps to decrease the inflammation in general, and also it helps to stabilize the mast cells. So that's good for when you have the mast cells is overactive. So it's turning off the inflammation in general, and that's good for managing any chronic inflammation or autoimmune disease in general. It also increased the expression of PD-L1. So that's very important for managing autoimmune diseases because PD-L1, it turns and all this effector cells or macrophages and T cells into Tregs. So it's turning off the immune system, those PD-L1 receptors. And when you turn off the effector T cells, and you turn them into Tregs and Mregs, definitely that would help to decrease the attack on the tissues mediated by the autoimmune diseases. So again, we understood that the COVID, the oxytocin can be directly antiviral by blocking the spike protein, attacking ACE2, and also by suppressing the protease enzyme, which is very important to activate the spike protein, allowing the spike protein to combine with ACE2. Without the protease, the spike will not interact with ACE2. So it has to be primed by protease. And it seems like oxytocin suppressed them
So that's a good thing about managing COVID. Okay, so let's go ahead and move to the other slides. So we mentioned that if we have two groups of mice or rats and we inject them with lipopolysaccharides to induce sepsis, right? And inflammation. And one group we inject them oxytocin, another one we did not. So we see the rats and mice who are injected with oxytocin, they last longer. Their lifespan is more longer than the one who are not being protected by oxytocin. So they die early, the one without oxytocin. And the reason because oxytocin counteract the inflammation that's being induced by the lipopolysaccharides, the hyperinflammation. And it's not just in the lung, but also in the brain. We know the liposaccharide causes microgliosis, and it seems like oxytocin prevent the activation or inhibit the microgliosis and inhibit the inflammation of the microglia. And knowing that, then we can use oxytocin to manage all neurodegenerative diseases, including neuroinflammatory diseases of the brain. Parkinson's disease, dementia, multiple sclerosis. Just by knowing it helps to inhibit the microglia inflammation, the microgliosis, or inhibit the microglia activation. And we explain how. We say it's buffering the NOx, it's buffering the redox, it inhibits the NOx enzyme, it inhibits interleukin 6, it inhibits the TH17, it inhibits the NFK beta, it inhibits the necrotic factor, the alpha necrotic factor. So it inhibits all this inflammatory cytokines, and it increased the expression of anti-inflammatory cytokines. And so we can use, that would justify the use of oxytocin in managing all neurodegenerative and neuroinflammatory diseases, right? Okay, and it's safe. It is something that you can use intranasally, it gets into the brain, it helps all those neuroinflammatory and neurodegenerative diseases. And I'm talking about multiple sclerosis, Parkinson, dementia, autism, drug addiction, all of those are neuroinflammatory conditions. Okay. Intranasal oxytocin attenuate cognitive impairment. And how is that? It helps to recycle the B amyloids and the tau deposition. So all those bad proteins, that's misfolded proteins in the brain that your in the brain cells, that your brain cells cannot get rid from it because the enzymes cannot break them. It seems like the oxytocin helped to prevent that from happening, from the misfolding, and also helps them to recycle them by increasing the expression of the machinery proteins that helps to degrade them. So that's one way of the mechanism. So they help to decrease them, and also it helps to decrease acetylcholinesterase. That's a good thing, right? So what would happen if you decline or decrease the acetylcholinesterase expression, gene expression? Then you would have more of acetylcholine bioavailable. Is that what we do in dementia? We give them the drugs that inhibit acetylcholine. Well, oxytocin does decrease the expression of the acetylcholine. That's a good thing, right? Through epigenetically. And that's mean it's a good candidate to be used for dementia. In addition, it helps to recycle the amyloids, those misfolded proteins. Those are free radical generators that causing a toxicity in the brain and damaging the brain. So we can use it for dementia. That's the reason I said, let's start recommending oxytocin for all the people intranasal above 40, because that's where the whole process of the neurodegenerative diseases start at that age. And if we can start from early, helping to recycle those amyloids and help to balance the inflammation and buffer the redox, then we can slow the process of the aging.
Dr. Halasa, we can barely hear you.
Okay, can you hear me now? Yes.
I don't know if anybody else is having trouble.
I think you need
I
to
can-
increase your voice
Better.
volume from your side.
I can
Because
hear you.
can you
good.
hear me, everybody? Can you hear me?
Yeah, you're doing good. It's better now.
Okay, I'm gonna buy a
can
new
hear you.
computer soon. So what, Dr. Rafael, once you join CDPMCS, part of that money we're gonna put buy a computer. Okay.
It's my
so-
fault, Dr. Halasa. I had
don't
my
worry,
phone
don't
messed
worry.
up.
Yeah. So so the other thing that we need to know is we want to see as much as of clinical applications of oxytocin. We said that it will work for all neurodegenerative disease, including Parkinson's disease, dementia. But do we have studies that show specifically it helps in Parkinson's disease? Really, this is something that's recently been discovered, or about oxytocin. It's just 10 years. And what we know in medical school, that oxytocin helps in delivery. It helps in nursing the baby by squeezing the muscles of the breast. But we don't know much about how it has anti-inflammatory and antioxidants, and how we can use it to manage. And we don't know that oxytocin that it's produced in muscles and in all your body tissues, and we have receptors all over our body, not just in the breast and in the uterus. So so now we start knowing that it's in your brain, neurons, the receptors. That's mean the oxytocin is not just stimulating the smooth muscle contraction of the breast and the uterus, but it has other effect on almost all the cells of our bodies. And it's a good effect. It's like in your computer you have the reset factory reset. I think this is oxytocin. It's a reset of our homeostasis, and by expressing all the good things, the anti-inflammatory cytokines, the analgesic expression of analgesic proteins of the analgesic neurons, a pathway. So it enhances the analgesic pathway in your brain. It helps to restore the neuroplasticity of the brain. It helps to inhibit the microglia, and they made a lot of experience there where they have mice and they try to toxicate or introduce toxins or to the dopaminergic neurons, and they find out that oxytocin has a protective effect.
Right.
So those mice will be injected with oxytocin, and those toxin, which is the retinol, they are more functioning versus the one that without oxytocin. They get Parkinson manifestation, or they manifest as a Parkinson or Parkinsonism. Those mice without oxytocin. So you can see that it gives that neuroprotection for the dopaminergic neurons. And we know that dopaminergic neurons in Parkinson's disease, they are being degenerated because of the they're unable to neutralize the quinin, which is part of catabolism of dopamine. So when they secrete the dopamine degrades into quinins, and the quinins, they're supposed to be recycled and neutralized because they're a free radical generator. But with age, it seems like the epigenetics that express the antioxidants that neutralize the quinins are not there anymore. They're not expressed too much, so that will lead to inducing all those free radicals and oxidative stress, which causing damage.
Dr. Halasa,
Yes.
here's the question for you, or a point to bring up, is that as I learn more about this, and if you listen to what the dermatologist said there and what you're saying, and really everything we learned about oxytocin, is that it's a pregnancy promoter hormone. It's related to all the bodily functions that lead to a successful pregnancy, delivery, and post-delivery childcare. And this is happening in the mother at very high levels of estrogen, progesterone, oxytocin during this time. And if you think, why would the body want to turn off inflammation at that time? Why would the body want to turn off damage to dopamine cells, right? The reason is that it's trying to give an evolutionary advantage to the mother here and to the child. It's reducing inflammation. It's making you look better. It's bringing a glow and healthiness to your skin. It's shutting down some of your aging and processes of that nature. So it's doing that to keep the mother healthy, it seems, because I think all of the things that you described, they're all tied together by that concept.
Of course, yes, you're 100% correct. I mean, this is just the oxytocin in the pregnancy and in our body in general, even with social connection and love and gathering in the church and gathering in the stadium watching football. All of this will increase
all that
oxytocin.
intimacy stuff and all this psychosocial stuff is all tied together by this.
And it's a healthy thing. And it's a healthy thing.
Yeah.
So people are lonely, no wife, no partner, no social interaction. They get sick, they get age. And why? Because they don't have that protective oxytocin, which is very important. Massaging, cuddling, stroking the skin, making love, all of this will definitely, it's a healthy thing. Mingling and even social gathering, that's part of, even in the Bible, in the Quran and all those scriptures, they ask us to connect to people and see your relatives and your father and your mother. And all this are not just for fun. And I mean, it's part of it. It's for our health and keeping our body health and optimized by the oxytocin. And if they cannot get it from all this, then you just call Dr. Mike Beamer. He will send you intranasal oxytocin. So that's another source of happiness. Just call Mike Beamer and he will send you the happy molecule. So again, we see that oxytocin has a cytoprotective, it restores the dopaminergic neurons. So I think it's a good thing for managing Parkinson's disease. Now, do we have studies? Do we have clinical trials for Parkinson's disease? None, we don't really. So they are starting, but this is where us as chronic disease prevention management, CDPM physicians, which now the CDPM become official name by the American Medical Association. They recognize CDPM as a new specialty, as a new field, and we need all to be part of it. And that's justify you to start managing all chronic disease across all medical specialty, because you can tell them, hey, I heard about the CDPMA program of the AMA, and I become CDPMEA, and we have a group of all of us as the doctors with your license and certificates and all that. Then you can create a board similar to any board, like neurology board, psychology board, gastroenterology board. We can create the CDPM medical board with Dr. Mike Beamer as a pharmacist, with all the doctors here, and we create a medical board like any other medical board, and we can create this medical specialty, especially if it's already been suggested and promoted by the American Medical Association. So this is something, we need to consider it if we want to work. And we need to start working on those clinical trials. Like Dr. Patel, she's working on doing intranasal oxytocin, and she wants to see the effect on the sex hormones level and how it's going to help to manage osteoporosis, how it's going to help all the symptoms of the postmenopausal. Is this oxytocin is enough? Do we need to have a sex hormone added? And with oxytocin, can we use less of sex hormones? And so Dr. Patel is working on that, on this project. There is none studies about sex hormones clinically with oxytocin and the synergy between oxytocin and sex hormones. And you can do the same thing. Who's seeing patient with Parkinson's disease? Let's try and see if with intranasal will work. And you can go up to 100 international units, with oxytocin per day. And with the enhancement technology that Dr. Mike Beamer is doing, or putting together the photodynamic therapy with methylene blue, I think we can get better results from whatever happened in the past or whatever studies happened in the past. There is a clinical trial that's FDA approved for using intranasal oxytocin for migraine headache. I don't know if it's yet, the drug is out there or not, but I think it is. It's recently, maybe it's FDA approved now for using nasal oxytocin for headache, especially the migraine headache. It helps to decrease the frequency, and because of its anti-inflammatory effect and because it's buffering the redox, and it has a specific mechanism for migraine itself. So we can start, using it as a compounding pharmacy. Oxytocin is FDA approved. You can use it for your patient with headache. And there is no harm using it because this is a natural product. We know it has been done, oxytocin for autism, some good results, some of them didn't get any much of difference. And possibly because of the delivery and the enhancement and the dosage. They use a smaller dose. I think they use less than 40 international unit. We can go up than 40, but there is some studies they see results out of it. Some they don't, others not. And again, maybe we need to add photodynamic therapy to enhance the delivery of oxytocin for those patients who are resistant of getting the effect of oxytocin. And I think Dr. Mike Beamer has a very nice kit for that. And as a doctor, you can go ahead and use your judgment and use whatever you learn, and especially things that's been published, that's something that's already been proven its safety, and start using it for a patient with autism and with methylene blue photodynamic therapy for patients who are not seeing much of results. Okay, so also it's very important to know that oxytocin can also help drug addiction. That's one of the big problem we have in pain management. What we're using opioid drugs, all of the opioid drugs cause oxidative stress of the brain and abnormal brain neuroplasticity and addiction. And I think I have a very big lecture on drug addiction of opioids and how it definitely causes damage to the neurons, especially the neurons that produce dopamine, and how the patient needs more of narcotics in order to obtain or get or reach to the level of the satisfaction. And so it has an addictive thing and has a rewarding thing because it does increase the dopamine. Okay, so can I increase the dopamine without oxidative damage, without the tolerance that the opioid does? So opioid increases dopamine, but also causes oxidative damage, and it causes abnormal neuroplasticity, and it causes dependency, and the patient needs more and more of the narcotics. And can we have something that will help to increase the dopamine without oxidative damage of the brain, without the abnormal neuroplasticity, and without addiction and tolerance? Yes, we can. Whether using CBD or oxytocin. Oxytocin, I think it's more powerful than CBD. And oxytocin does increase the dopamine. So it helps the patient to feel the satisfaction they need without causing tolerance that the opioid does, because opioid causes oxidative damage, and oxidative stress causes down regulation of the mu receptors. If you down regulate the mu receptors, then that's a problem. Then you need more of the narcotics, right? In order to produce more of dopamine and give you that analgesic effect. But oxytocin does not cause, but in fact, it's antioxidant, same like CBD. So it will not cause a down regulation of the mu receptors. So it will not lead to tolerance. And so I can use oxytocin to wean patients from narcotics, giving them the dopamine kick they need without suppressing the mu receptors, without causing oxidative stress, without causing this abnormal neuroplasticity, especially in the pain pathway where the pain gets even more pain. Because when you increase the neuroplastic changes in the pain the nociceptive pathway, you aggravate the sensitivity of pain. So that's the problem with opioids.
you're giving them for a long period of time, then what would happen? Patients look like zombies. They get their pain tolerance. It will lower the pain tolerance, and it will cause them more hypergesic, allodynic, because of the downregulation of the mu receptors, because of the neuroplastic change that happened to the pain neuropathy, the pain neurons, and they start connecting with each other more and more and become more sensitive to pain. And so you need more opioids. And because of downregulation of the mu receptors, you're not getting enough of dopamine. So you need more of opioid, you get a drug addiction. And so oxytocin will give you all the things that you need. It gives you the dopamine without downregulation of the mu receptors. It has an antioxidant effect, so it will restore the neuroplasticity of the pain neurons back, returning back the pain sensitivity to normal. And also it has an analgesic effect. And the analgesic effect of the oxytocin is almost equivalent to morphine. Now, there is studies and cases where they are injecting 2 international units of oxytocin epidural as a replacement of cortisone. You can go ahead and morphine intrathecal. You can use oxytocin epidural, and you can get the analgesic effect you need, because the oxytocin stimulate the serotonin, it stimulates the enkephalin, it stimulates the GABA. So it stimulates all the analgesic descending pathway that you need to suppress the pain pathway. I think oxytocin is the analgesic neuron or analgesic drug that we're looking to replace all the current opioid drugs, and possibly because of its anti-inflammatory and antioxidant, we can use it to replace steroids. So my suggestion for pain management is to use platelets nanoparticle loaded with oxytocin and procaine. Procaine is better than lidocaine because procaine has anti-inflammatory regenerative effect. Oxytocin has anti-inflammatory regenerative effect, analgesic effect, anti-inflammatory effect. It's better than cortisone, and I think it will the new pain management protocol, the new ingredients for pain management, instead of using opioids and NSAIDs and all those neuroleptic drugs, which has a long-term damaging effect because of its oxidative damaging effect. It causes oxidative stress. All those big pharma, including the NSAID, it has an oxidative damaging effect. We can replace it with something that is natural product with almost the same anti-inflammatory, analgesic, regenerative, and anti-inflammatory and antioxidant effect. So we can use oxytocin for drug addiction, for all the drug addiction out there: alcohol, opioids, marijuana, everything that's being abused. We can use intranasal oxytocin as a management for that. We just talked about intranasal, especially for pain. It does help to increase or stimulate the opioid. It stimulates the enkephalin. It stimulates the endocannabinoid receptor system. It enhances the descending analgesic pathway in general. There is oxytocin receptors in your posterior horn of the neurons, where we receive the pain fibers or the pain pathway. There's receptors there, and oxytocin does inhibit those pain pathway, pain signals, the ascending pain pathway, and it enhances that analgesic descending pathway. Knowing that we can use oxytocin intranasal to treat pain, and using it for pain management and also for a drug addiction. And as we see here, oxytocin not only suppress the drug rewarding, but also it reduced the stress response and the social impairment during the withdrawal. So don't worry about the withdrawal.
because oxytocin will help to increase the dopamine and the serotonin, so you don't get depressed after withdrawing from cocaine or heroin or alcohol and all that stuff. And so it gives you the analgesic, plus it gives you that rewarding effect as a replacement of the rewarding effect without damaging the brain. Okay. So intranasal administration of pain, particular chronic pain remain one of the most debilitating and difficult to treat condition in medicine. We know why, because all those drugs that we're using, it has damaging effect. It has oxidative damaging effect, and it has addiction, and it has it causes abnormal neuroplasticity of the brain. It impairs the social life of the patient, and they get addicted with it. Plus the damage of the brain with narcotics, or the damage of the kidneys and the GI with the NSAIDs, or the neuroleptic drugs. All of them cause interference with the mitochondrial function and oxidative stress with long-term use. So chronic pain is difficult to treat, in part because it's associated with plastic changes in the brain. We talked about when you have oxidative stress, opioids in general cause oxidative stress. And it causes the downregulation of the mu receptors, the tolerance and inflammation of the brain, the microglia inflammation, that leads to neuroplastic changes of the brain. And it causes that neuroplastic, especially in the pain fibers, where they become more sensitive. Think about all those pain fibers are connected with each other, even connecting to the touch neurons, where they develop what we call the allodynia and eventually hypergesia. So current treatment of chronic pain can have adverse side effects and rarely result in a solution of the pain. As such, there is a need for adjuvant analgesic that is non-addictive, non-oxidative. It does not cause the abnormal neuroplastic change in the pain fibers and increasing sensitivity of the pain pathway. It has a few side effects and are effective for pain management across several chronic pain conditions. I think the oxytocin is the answer, and oxytocin can be used intrathecal. There's studies about it. It can be used epidural. It can be injected anywhere you want, IV, intranasal, topical. It's a natural product, so just go ahead and continue. I mean, just start, using it, and then report us about the effect. So oxytocin is transported to an area involved in pain modulation. Yes, an analgesic pathway are very rich with oxytocin oxytogenic neurons, and they secrete oxytocin. There's oxytocin receptor, and they inhibit the pain pathway, the neurons that carry the pain to the brain at the level of the spinal cord, at lamina 1 and 2 and 4 at the dorsal horn. And also they inhibit the pain signaling in the hypothalamus, through the hypothalamus spinal projection. And so we know that it does stimulate the mu receptors. It does stimulate the enkephalin receptor, the GABA receptors, and so we can see that oxytocin is a powerful analgesic neurotransmitter. And so the analgesic effect of endogenous and exogenous oxytocin can be blocked by the opioid antagonist. So that's give you really an understanding that oxytocin, indeed, it blocks the opioid receptors. Why? Because if you give opioid antagonists, you can nullify the effect of the oxytocin. Just to give you an evidence that it helps and it stimulates the opioid receptor. It's just a proof for that. So it's buffering the redox, it's anti-inflammatory, it's antioxidant, it's everything that you need to manage pain, centrally and peripherally. And so it definitely helped to calm the patient and increase the sensitivity of pain and all that stuff, decrease the sensitivity of pain. And I think it's the best drug up to now that I know for pain management. Okay, so we can give it intranasal to get into the hypothalamus there, into the brain, or we can use it also epidural or intrathecal. If we just start with intranasal and then we move to with epidural, that would be great. So oxytocin also, it's good for cardiovascular because of its anti-inflammatory effect, antioxidant effect. It does lower the LDL, especially the oxidized LDL. It definitely helps to decrease the atherosclerosis. It helps to regenerate the heart, the muscles. So it helps to regenerate the muscles and decrease the scar tissue after cardiac attack. So it has a regenerative effect, anti-inflammatory effect, antioxidant effect. It stimulates the nitric oxide, so it improves the endothelial function. Is that what we need when cardioprotective? So the beneficial of oxytocin and on infarct and functional recovery of ischemic reperfused heart. So we know that when you have the reperfusion, you have the oxygen is coming in into the ischemic heart portion of the heart. When we have a myocardial infarction, what will happen? You have a lot of free radicals that can cause more damage and more damage. Oxytocin prevent the reperfusion, oxidative damaging effect when we have the myocardial infarction and we start giving oxygen and all that. You need to protect the heart from those free radicals that generate from the reperfusion and opening up. When you open up those blood vessels and they start supplying oxygen to the ischemic heart, you may generate extra free radicals that can cause more inflammation and more damage in the heart. Oxytocin will help that to prevent or protect the heart from the ischemic reperfused. And so we can start think about using oxytocin as part of management of heart attack, not just using morphine and anti-inflammatory, which is aspirin. I think we need to add oxytocin to the protocol. Is that in the mainstream medicine? No, it's not yet. Can we add it? Yes, that's why we're going to have a board of chronic disease prevention management, and we're going to do clinical trials. We're going to say, hey, oxytocin is part, maybe IV or intramuscular. It's as important as giving morphine and an aspirin. It's not yet in our protocol in all the hospitals in the United States and the whole world. Nobody used it yet. But this is how we advance medicine, right? And we can start from our group as chronic disease prevention management, recommending it because we don't see any harm, and we translate all these publications. We need to see trials, but none of the big pharma will be interested in those trials because they cannot really patent it. So I don't know. So evidence indicate that oxytocin treatment improve cardiac work, reduce apoptosis, inflammation, and increase the scar vascularization. Oxytocin mediates cytoprotection, as we know, it's same like in the brain. Involve the production of cyclic GMP, which will help to increase the nitric oxide. It increases the blood flow. It releases the arterial natriuretic peptide, which helps to diuresis and get rid from extra of the fluid. Senses of nitric oxide, which is very important to improve the endothelial function and improve the blood flow, right? Because the nitric oxide is vasodilator, and it helps to improve the mitochondrial function because of it inhibiting the MOX enzyme, which will, especially when we have all this sympathetic overactive due to the stress, and we know that norepinephrine stimulates MOX, and we know that oxytocin inhibits the MOX, which is good, and it stimulates the vagus nerve, right? So treatment of oxytocin reduces the expression of pro-inflammatory cytokines. We talked about it, interleukin 6 and the TH17, MC17. It reduces the immune cell infiltration. Oxytocin stimulates differentiation of stem cells. Here's the thing. This is what I need you to know. It stimulates the stem cells. Okay, so that's good. So we can load oxytocin in PRP, and we can use it as regenerative molecule. If the big pharma and the FDA, they have problem with exosomes from the umbilical or from, then we say, okay, let's go ahead and use PMP, related cytoparticle, and load it with oxytocin and get the regenerative effect that we are looking for. So it stimulates differentiation of stem cells to muscle cells, not just for muscles, but also for neurons and for bones. We can see that it stimulates the release of the bone marrow cells into the blood. So that's a good thing. Oxytocin stimulates differentiation of stem cells to cardiomyocytes, to skeletal muscles as well, lineage, as well as generate endothelium and the smooth muscles, and promoting angiogenesis. And the beneficial action of oxytocin may include increase the glucose uptake because it increases the sensitivity of the glucose receptors, right? To increase the the insulin sensitivity, and also the insulin production. And it decreases oxidative stress. So you have everything that you want to really manage cardiac attack and myocardial infarction and ischemic attack, and possibly intranasal oxytocin will be part of the treatment of angina, right? So I want you to be creative here and start using it for all those patients and give us your inputs, because nobody has done it yet. It's all still embedded in the research, and our job as chronic disease prevention and management centers, as Nitro Medicine, we translate all of this work into clinical protocol with the help of Dr. Mike Beamer as a compounding pharmacy. He can translate and take those into pharmaceutical products that you can use in your clinic without the need to wait for 10 and 20 and 30 years to be approved as a drug or to be approved as a protocol by FDA. Of course, who's going to take the oxytocin to be approved in those clinical applications?
No.
None. Nobody will be interested in, okay? Because there is no money in it, and it will stay in the research and nobody will benefit from it. But us as chronic disease prevention management, repurposing drugs and making things, try not to be butt heading with the regulatories and try to go with the flow, right? So you don't be crushed like a bug by those chides, right? Okay, so chronic heart disease, therapeutic potential of oxytocin and atherosclerosis and cardiovascular disease. We know that it lowered the LDL, decreased the oxidative stress. That's mean it decreased the oxidized LDL. We know it decreased the nitric oxide, so it improved the endothelial function, smoothing up the blood vessels, and definitely would help to manage the atherosclerosis, right? So the major pathophysiologic basis of coronary artery disease is atherosclerosis association with varieties of immunometabolic disorder, increasing the lipids, especially the oxidized one, the LDL that's oxidized, oxidative stress, right? Inflammation as well, especially interleukin-6. We talked about it. That does cause a destruction, inflammation, and so if we are able to inhibit interleukin-6 and we help to increase the sensitivity of the insulin receptor, and we help to decrease the oxidation of LDL, and also we help to decrease the weight, causing weight loss. All of this will definitely help in managing cardiovascular disease. And oxytocin has anti-diabetic, it has anti-lipidemia, or it definitely helps to decrease the lipids or the fats, circulating fat, especially the oxidized forms of oxidized LDL, which cause the damaging and the endothelium, and also it decreases the inflammation that causes destruction, which is inhibiting interleukin-6. So this immune metabolic, managing this immune metabolic disorder of the atherosclerotic disease, it's what the oxytocin can do for you, right? And increase the nitric oxide, improve the endothelial function. All of this is in favor of managing atherosclerosis. So oxytocin in metabolic homeostasis, implication of obesity and diabetes. We know that it does help to increase insulin, the endogenous one. It increases the sensitivity to the insulin. So that's mean it helps to get rid from the extra sugar in the blood. And when you are able to push all the sugar from the blood into the tissues, you decreasing the hyperglycemia. And when you decrease the hyperglycemia, decrease the chance of those sugar being oxidized and become become oxidized glucose. We call them glycated, and those are the one who's causing the damage in the blood vessels. You don't want to have oxidized glucose in the blood, because those are the glycated ones are causing the damage in your endothelium and accelerate atherosclerosis. And you don't want that. So oxytocin does inhibit that. So it decreases the glucose uptake. It decreases the utilization of fat. So it breaks down the fat. It causes weight loss. Is that what you want? And also decrease the appetite. Okay, well, how would decrease the appetite? We know when we eat fat, what would happen? The fat will go to your fat cells. The fat cells will get a little bit bigger.
And the fat cells, when they get bigger, what they start secreting leptin, and leptin will go to the hypothalamus, and the hypothalamus will stimulate the secretion of oxytocin, and then the oxytocin will help to suppress your craving of food, especially in general, craving of food. So leptin works through oxytocin. So if you have a patient who's obese, but they have leptin, but they are resistant to leptin because their receptor of leptin is not working for a genetic reason. Now, how you can manage those patients? We know that oxytocin is the downstream molecule of the appetite or the function of the leptin. So we can give those patients oxytocin and bypass that. Okay? So oxytocin helps to decrease the appetite. It helps us to lose weight. And as I said, we know that even through a leptogenic system, that oxytocin is the down signaling of the leptin. So if there is any resistance of leptin, you still can use oxytocin and bypass any insensitivity to leptin. So it enhances the glucose uptake, liver utilization, burning the mitochondria. That helps to stimulate the mitochondria. It turns the white fat into brown fat by increasing the mitochondria production. We know it increases the biogenesis of the mitochondria, oxytocin, and also it increased the sensitivity to insulin. That's mean more of sugar uptake, and also to improve the mitochondrial function in general. So it does help to reverse the pathogenesis of insulin resistance and dyslipidemia. And so this multi effect of oxytocin signaling, improving the peripheral insulin sensitivity, it increases the pancreatic secretion of insulin. All of this would help in managing diabetes and obesity. So I think we need to start. I think I have Dr. Stephanie here. He used it for a patient with, I think he's going to present that a case where he said, I have a patient with 400 sugar, and when we did the intranasal oxytocin drops it to 80. That's a good news, right? And now he's thinking about you don't need all this anti-diabetic drugs if we're using intranasal oxytocin. So we need more of Dr. Stefani, with the same work that he does. Can we have doctors doing it for pain, like Dr. Rafael Cruz? He's pain management. Can we get some cases from him, or Dr. Joseph James? I think he's already doing it. I mean, they are more advanced. Dr. Joseph James and Patel, they are way ahead of us. I mean, they're using it with PMP and intranasal, all the stuff they're using it. So they are the most advanced doctors in our group right now. So I really give them my salutes. Chronic oxytocin administration as a treatment against impaired leptin signaling or leptin resistance of obesity. I know we talked about, right? We said that how the leptin works, and when you eat fat, what will happen to fat goes to the fat cells. When the fat cells swell, they secrete leptin, and then leptin goes to the hypothalamus, goes to the lateral portion of the hypothalamus, and they secrete oxytocin. Oxytocin causes suppression, makes you not feeling hungry anymore. And so if you have problems with any of this leptogenic pathway, you have problem with the receptors of leptin, then you can bypass it with oxytocin, because oxytocin is downstream of leptin. And so you can bypass that. So we can use oxytocin as a way to manage obesity and diabetes and weight loss and hyperlipidemia or lipid disorder, name it, all the metabolic disorder. If we do that, we can manage also hypertension. So oxytocin is good for metabolic disease in general, right? Okay, so I think that's the answer here. Peripheral oxytocin treatment ameliorate obesity by reducing the food intake and visceral fat mass. So we talked about it, right? We said oxytocin inhibit us or decrease the desire for eating food, but also it helps to burn the fat. It helps to burn the fat by turning the yellow fat into the white fat into brown fat, right? The white fat into brown fat by stimulating the mitochondrial production. And when you have more mitochondria, the white fat turns into brown fat and then burns it, and you get rid from the fat, especially the visceral fat. One of the problem, myself, I mean, when I try to remove some fat, me and Dr. Joseph James in Milwaukee Clinic with Dr. Sandra, They took fat from me, but there's not much fat under my skin. Most of my fat is in the viscera, in the abdomen. And so even if we do liposuction, you may not be able to completely get rid from the belly. And the reason, because the fat is not hidden under the skin. We got rid from all the fat on the skin. It's in the viscera. And so intranasal oxytocin is the answer for that, right? And I think I'm taking it, and I'm exercising as well. I'm not doing dieting, but I'm doing some sort of fasting, you know, but I would do regular fasting from now on, because proven that fasting is better than dieting. And I'm doing lifting weight as well. So I saw Dr. Joseph James with the, you know, he's getting muscles. So I thought, you know, I want to do the same. So I'm using nasal oxytocin from Mike Beamer mixed with methyl and blue. And I'm exercising now. I hope I'll be building muscles. And I would encourage everybody to do that. I mean, just get the weight bench, you know, and start, you know, there's exercise where you start bending forward with the bench is in clean. And I think that helps in exercising your stomach. Are you there, guys? I'm talking too much, right? Hello? Can you hear me, guys? I'm still live.
Oh yeah, just
Are you enjoying it? Hopefully, I'm
just taking it in.
I'm trying to have some sense of humor here, not to you know, entertaining you with my accent, my broken accent.
You want a resistance training lecture? I can give you one.
So oxytocin acts centrally in the brain to improve the leaky gut through vagus nerve and cannabinoid signaling in the rats. That's a good thing, right? So when we have leaky gut syndrome and we want to manage it, we can use oxytocin. And how it works? Well, the oxytocin does help to increase the vagus nerve, and vagus nerve inhibits the sympathetic. We know the sympathetic in the gut, what will they will lead to release of norepinephrine. Norepinephrine stimulate the NOx enzyme. The NOx enzyme generate free radicals, and those free radicals, too much of free radicals can cause contraction of those endothelium that lines the gut and close the opening of the tight junctions, allowing all those toxins to get into the blood, from the gut into the blood, and that is the leaky gut, right? So if can we reverse that? Yeah, if I stimulate the vagus nerve and I block the sympathetic, I decrease the norepinephrine, I block the NOx enzyme, and we know that oxytocin blocks the NOx enzyme, then I decrease the free radicals, I decrease the contraction of those endothelium that lines the gut, the epithelium that lines the gut of your colon and your GI. And this will prevent the leakage of the free radicals generators, the lipopolysaccharides, all those heavy, those toxins in your gut from leaking into the blood by reversing that. And in addition to that, we know that oxytocin inhibits interleukin 6 and Th17, and we know that overactive Th17 and interleukin 6 can lead to leaky gut as well. So that's the good thing about oxytocin. Reduce the improve, and also oxytocin induce improvement in colonic hyperpermeability, mediate central ghrelin and oxytocin induce improvement of intestinal barrier function, barrier function. So we know that the ghrelin is part of as well of it helps to stimulate actually the desire to eat. But it seems like here the oxytocin has through this, it helps to improve the intestinal barrier function. We will therefore suggest that activation of central oxytocin signaling may be useful in leaky gut related from the endogenous oxytocin, or using intranasal oxytocin. That's another way from exogenous. Okay, oxytocin system alleviate intestinal inflammation by regulating macrophage polarization in experimental colitis. We talked about oxytocin inhibits the NOx enzyme, it inhibits the interleukin 6 in the macrophages, so it inhibits the polarization into Th17, M17, interleukin 6, and neutrophilia, right? And we see that especially ulcerative colitis, it's really more of Th2, Th17 dominant immune inflammation and ulceration of the gut. And having oxytocin as an anti-inflammatory inhibiting the Th17 interleukin 6, I think it would help to reverse and heal the colitis, especially the ulcerative colitis, but also Crohn's disease, because it's part of it is Th1, yes, cytotoxic, but also part of it is Th17 as well. So it's a combination of Th17, Th1. If we get rid from the Th17, we can have improvement of both ulcerative colitis, which is Th2 dominant with Th17, and Crohn's disease, which is Th1 dominant with Th17. So if I can get rid from, or I can decrease the inflammation of the Th17, I can help both side of colitis, or any form of colitis, bacterial colitis, autoimmune colitis, inflammatory bowel diseases in general. The good thing about oxytocin, it does stimulate the stem cells of the muscles, and it helps to regenerate the muscles, skeletal muscles. So they took some mice and rats, old ones, and two groups, and they inject them. One group, they inject them with oxytocin, those old rats, and then the other old group of rats without oxytocin. And they took the cross sections, and they see the difference. In rats being treated with oxytocin, their muscles, tissue cross section, it looks like young mice or rats. It's rejuvenating and causing youthfulness of the cross section histology of the old rat muscles treated with oxytocin versus the old rat muscles that are not treated with oxytocin. So it does have that regenerative effect on the muscles. It helps to strengthen the muscles. It increases the mitochondria. It has anti-inflammatory effect. But also, we know that when we get obese, we get fat, the fat itself can cause atrophy in the muscles for some reasons, because of the fat is a source of inflammation and possibly that cause destruction of the muscles, and cause that's the reason why when we grow in age and we have more fat than muscles. And I think if we can reverse that by using oxytocin. Oxytocin will burn those fat, which is inflammatory source that cause atrophy of the muscle itself, and we can build the muscles more through its regenerative effect, anti-apoptotic effect. Also, we know oxytocin helps to get rid from all the senescent cells, which are inflammatory cells that cause more damage and more atrophy of the muscles. We can say oxytocin, yes, it causes regenerative effect of the muscles, but also stimulate the testosterone. And there is reciprocation there. There is testosterone and oxytocin work together, enhancing and synergistically helps to increasing the strength of the muscles. So testosterone stimulate the oxytocin, and the oxytocin stimulate the release of testosterone. That's in the muscles, so they work synergistically. But in the brain, they may have some antagonist effect, especially in the behavior. Maybe testosterone is causing more aggressiveness. Oxytocin will help to decrease the aggressiveness. That's the reason when you give sex hormones, please give oxytocin with it, because you can minimize the side effects of all those sex hormones, especially the aggressiveness that's coming from testosterone or any side effects from using testosterone. Testosterone can cause fatty liver. Oxytocin inhibit the fatty liver side effects. So please use intranasal in all your patients who are on sex hormones. Please use oxytocin. You can get better because of synergy between oxytocin and sex hormones. There's a lot of synergy, even between oxytocin and estradiol. There's a lot of synergy. Estradiol works by increasing the oxytocin, and oxytocin does all the good effect, like it helps to strengthen the bone and help to rejuvenate the bones and the muscles. But also, oxytocin helps the sex hormones from doing all those other effect that oxytocin sex hormone does. So there is reciprocation. Some studies, they say
all the oxytocin, sex hormone effect is through oxytocin, as it is the downstream signaling of the sex hormones. And it could be kind of reciprocating synergistic relationship between both of them. So I think intranasal oxytocin improved the lean muscle and lowered the LDL and cholesterol in older adult with sarcopenic obesity. We know that when you have too much of fat, that fat inflammation can cause atrophy of the muscles. And so it's good to reverse that by using oxytocin and shrink that fat and buff and beef that muscles with oxytocin. And it does help to, we know it helps to decrease the LDL in the blood. It helps to increase the sensitivity of insulin, which means that it helps to increase the glucose reuptake. It helps to burn the fat. And it helps to build, it has anabolic effect, the oxytocin, anabolic effect, and it helps the catabolic of the muscles, of the protein. So in general, it anabolic to the protein, so it's a protein anabolic, but and inhibit the catabolism of protein, but it is catabolic for fat, and it breaks down the fat and shrinks the fat. So that's the oxytocin. So try to use it for people who are trying to especially the bodybuilders like myself. I'm trying to become a bodybuilder, trying to increase my muscles. I think all the doctors here needs to have some mini gym in their offices. So when they have break, they go in and just get those muscles stretched and exercise, because exercise itself, it helps to increase oxytocin. So oxytocin is not just produced by posterior pituitary. It also produced peripherally in your muscles. Your muscles produce them. Your bones produce, everybody, all of our tissue produce oxytocin, and you can increase the oxytocin production just by exercising and stretching the skin, as massage and exercise. All of this helps to increase oxytocin and optimize the health. And if you don't want to do exercising and you don't have time, at least call Dr. Mike Beamer, and he will send you the intranasal oxytocin. So oxytocin induces anti-catabolic, but it has anabolic effect on protein metabolism, in general, male and female. And so it does help to manage osteoporosis. So we know the sex hormone, we use it for managing osteoporosis. We use nitric oxide to manage osteoporosis. We use nitroglycerin also. You know that we can use nitroglycerin to manage. So nitric oxide and sex hormone. But if you see the mechanism of action, well, sex hormone stimulate oxytocin, and oxytocin stimulate the NOx, and the NOx generate the nitric oxide, and nitric oxide stimulate the osteoblast cells to lay down more collagens and more bone, and inhibit osteoclast. So if you see here that oxytocin maybe mediate the action of sex hormone, and then the nitric oxide mediate the action of the oxytocin. So it's a good thing to manage osteoporosis. That's a good thing. So strengthening the muscle, strengthening your bone, managing the all this, the neurodegenerative disease and all that, cardiovascular. I mean, come on, it's just a tool that you can use as chronic disease prevention and management. This will be the first drug of choice to really manage chronic disease across medical specialties. It's not yet in the mainstream medicine. Our group will take it to the mainstream medicine. So how we can do that? Is 30 people here? How many people we have here? 24 people here enough to redefine the medicine? No. We need to have hundreds and thousands of doctors to redefine medicine and change the technical part of medicine. And the only way we can do that is having chronic disease prevention, CDPM centers in its state. And if we have 24 centers from those 24 doctors here, then the 24 will become 50 and 50 become 100. So we need to start moving to that direction and changing the landscape of medicine or practice. The more doctors on our side, the more we can help patients. Because big pharma, don't expect big pharma will use oxytocin or promote oxytocin or added in the mainstream medicine protocol because there's no money for the big pharma. So the only one who's going to be using it is us as a group of doctors who's looking for the best interest of the patients and not for the best interest of the CEO of the big pharma. Okay, oxytocin alleviate oxidative renal injury, pyelonephritic rats. Of course, we know that it blocks the NOx enzyme. It inhibits interleukin 6. So when you have pyelonephritis and you have bacterial infection, you have too much of inflammation, especially the Th17 and interleukin 6, which goes damaging. You need the Th17 for killing the bacteria. You need neutrophilia to kill the bacteria, but you don't need too much of it. So it helps to tune down the inflammation. So it's enough for just destruction, destroying the bacteria, but not causing the damage into the kidney. And so because of that, we can start using oxytocin for managing kidney diseases in general, any inflammatory oxidative stress in the kidney, and not just kidney, in the brain and the muscles, in every organ of our body. It has this cytoprotective effect because of its antioxidant, anti-inflammatory effect. Oxytocin alleviate cellular senescence through oxytocin receptor mediated extracellular signaling and regulate the kinase and NFR signaling, which is the one responsible for expressing antioxidant enzyme. And also it helps to get rid from the senescent cells by inducing apoptosis, and also it decreases interleukin 6, which is causing all this neutrophilia and inflammation and damaging and aging process and damaging of the collagens and disfiguring the skin. So also we see here it does inhibit the senescent cells from secreting this senescent associated secretory phenotype, which is the SASP. I think we heard that from the doctor in the beginning of this lecture, was talking about the anti-aging effect of the oxytocin by inhibiting the SAPs. And SAPs are those vesicles contain signaling molecules that will induce inflammation, that will induce polarization of the immune system to Th17, hyperinflammation, interleukin 6, and neutrophilia, and damaging to the skin and aging and fibrosis. So we need to inhibit that. We need to induce apoptosis and get rid from those senescent cells and get rid from and inhibit their secretory effect and inflammatory effect and their oxidative effect. And the only way we can do that with oxytocin, which helps to increase the expression of antioxidant, anti-inflammatory, and get rid from the secretory effect of senescent cells and the senescent cells themselves as well. Okay, so we can use this for skin anti-aging, right? Effect of oxytocin administration on salivary sex hormones level. So we don't have much of clinical work on this field. We know that oxytocin does help to increase the testosterone production. We know there's synergy between estradiol and oxytocin, synergistic effect. So we can tune the effect of sex hormone, make it more effective by adding oxytocin in the equation. By doing that, so we can improve all those sex hormone therapy and minimize any side effects. If anything about those doctors mainstream, those sex hormone causing liver, fatty liver, increasing the clotting factor production, all that stuff. If you use oxytocin, then you can nullify all those, any side effects from sex hormone, if there is any out there. So this is a good tool for Dr. William Bill, because we know his expertise in sex hormone, to add intranasal oxytocin in his in the equation. Okay. Let's go with anorgasmia. We have cases of people who have problem, they don't get erected, they have problem connected with females, and they don't have the sensitivity that drives them for passion and making love. So they can see a naked woman and they can see all that, but still they're not getting aroused. We can treat it with oxytocin. Just give them oxytocin. It heightens the sexual sensitivity, the bonding, the passion, the attraction, especially with testosterone. You can combine it so you can have that. You can add a sexual orientation to it. So a combination of oxytocin, testosterone, I think it's a good treatment for anorgasmia. And that will heighten the feelings. And so there's cases who's being treated with that, especially with male. So I think because of the bonding effect and increase the sexual desire, especially monogamy desire, not polygamy, because they made a study and they give people this and they see that they don't really care about other people. They care more and bonding more with their wives, and what it has some monogamic effect. So it's good to maybe decrease the rate of divorce. Oxytocin, because we know the divorce rate is very high. So I think if this lecture is being heard by a lot of women, they will encourage their husbands to start taking oxytocin so their husband will not cheat on them, and vice versa as well. Okay. And so we know oxytocin effect inhibit the NFK beta, which is responsible to generate the free radicals. You need to buffer that. You don't need to have too much of active NFK beta, because then you have pathological free radicals. A spark of free radicals is good because that will induce the expression of antioxidant enzyme, but too much of activation of NFK beta is not good, chronic active. So I think oxytocin will inhibit the chronic active NFK beta. And if you do that, then you can also help to manage breast cancer, right? If you decrease oxidative stress, the inflammation, especially interleukin-6, which actually drives the immune system, polarizes the immune system away from the Th1, which is very important for immune surveillance of cancer. Then this will help to prevent patients from having breast cancer for females. That's the reason I like to encourage all the women above 40 to start taking intranasal as cancer prevention for breast and many other cancers, not just for breast. But also, the oxytocin squeeze the breast tissue, so it gets rid from all those senescence and harm tissues into the secretion out of the mammary gland just by using the oxytocin. And we know that oxytocin endogenously we can get it from making love or having babies. And then they've made a study and they find, ladies who are not nulparous, which they are not pregnant, and never been pregnant, they have higher risk than cancer than the one with multiparous, with women who have many pregnancy. And the explanation here is because of oxytocin. Making love, having babies help to decrease the chance of the risk of cancer. We know the cancer risk is flip of the coin, right? 50-50. And if we do anything that helps to decrease the chance of having cancer, I think it's a good thing. And recommending intranasal oxytocin, it's not a bad thing to do from all different perspective and benefit that oxytocin can do to our body. And so oxytocin, as we say, it helps to improve the tumor microenvironment in the favor of destroying the tumor by inhibiting interleukin-6, by inhibiting the fibrosis, the protection of the cancer cells from the fibrotic tissue, and polarizing immune system away from Th1 and M1, moving it to Th17. Inhibiting that helps to polarize the immune system to Th1 and get rid and cytotoxic T cells and get rid from any cancer that's trying to emerge. But also it helps for, they find out patients with ovarian cancer, even for advanced stage, if they they ask them to stay with their family and have the social support and family support and emotion, all that stuff, and faith, all this emotional family support, all that does increase oxytocin, and oxytocin helps to improve the tumor microenvironment, and it helps to slow the progression of the cancer, and it slows the process or the timing of death. So if you have a female and a doctor say, hey, you're gonna die after 3 months, you're gonna have cancer, you're gonna die after 3 months, don't worry, you don't need to do anything, just die peacefully. That kind of news may cause depression and oxytocin because they become hopeless, and that will speed the process of dying. But if you say to the patient, hey, yes, you have a cancer, but social support, emotional and faith, and
worshiping and all that stuff, what we do in gathering and family support and making love and all that, it may help to slow the process of the cancer. I hear some cases where they went to a religious area and they healed from cancer. That's possible because of the power of love and power of oxytocin. So yes, power of love can do a lot of things here. So if we go to this figure here, and we can see the network of oxytocin, how it's managing all chronic disease across all medical specialties, whether it's buffering the redox by blocking the NADH oxidase, or inhibiting the NFK beta, or inhibiting the TH17 and interleukin 6. Or we see here, this goes in managing all the neurodegenerative and neuroinflammatory diseases and decrease the microglia inflammation and the neurotoxicity and restore the neuroplastic changes of the brain. It helps in cardiovascular because it does help to decrease the lipid, the LDL in the blood. It helps increase the glucose uptake, the sensitivity of insulin. It helps to decrease the sympathetic tone, helps to increase the free radicals, it helps to decrease the nitric oxide. All of this is buffering the redox, which helps the damage that's caused by ischemic reperfusion inflammation. So that's why when you have cardiac attack or you have myocardial infarction or you have angina, I would recommend adding oxytocin in the protocol. We know that GI system, if you have colitis inflammation, then oxytocin will help because it will help inhibit interleukin 6, buffer the redox. And doing that, you would have the TH17 mediated inflammation of the colitis, whether it is ulcerative colitis, which is TH2 dominant, or Crohn's disease, which is TH1 dominant. So it lowers the inflammatory cytokines, including the tumor necrotic factor alpha. You see here that in muscles, skeleton, it does help to increase the muscle rejuvenation of the muscles. Skeleton muscles help to strengthen the bones. It helps to manage osteoporosis. It helps to increase the glutathione level, so it helps and buffer the redox and inhibit interleukin 6, and so it helps the neuroinflammation, pyelonephrites. We know that it helps the weight loss. It helps to shrink the adipose cells, increase the catabolism of fat, increase the anabolism of protein, and it helps to increase sensitivity of reuptake of sugar, which is increased sensitivity of insulin, production of insulin. All of this helps to manage all this metabolic disorder. And also it helps to mediate the effect of leptin, which decrease the food intake, and it helps to give you that set. It stops you from being craving food. It also, we see that we can use it for post COVID-19. We can use it for COVID and acute infection. We can use it for pneumonia. We can use it for anything that caused septic damage or chemical damage or mechanical damage of the lung, because of the antioxidant, anti-inflammatory of oxytocin in the lung. So we can use it for all this inflammatory disease of the lung. Again, we can use oxytocin for anti-aging, we can use it for cancer, we can use it for pain, and we discuss all of that. So let's go ahead. I think we're done from the lecture here, and we will, I want to hear the questions from the audience. Are we good?
Yeah, I was just going to give you give some feedback from my end, because I've been doing it now for a few weeks, and of course, I'm noticing other changes since I started. As time goes on, you start to notice some of these things, and some of the things I didn't realize until this lecture. Like, I didn't realize, well, I haven't been really drinking wine that much, In fact, it's almost like I've forgotten about it, but I didn't realize that it had an effect on alcohol, or at least the receptors involved with alcohol. The other thing is I started doing intermittent fasting, especially after it was either last week's lecture or a couple of weeks ago, when we were talking about getting rid of the spike protein and the possibility that we have to increase apoptosis if the virus is staying in our, say, for example, our immune system. And, you know, and I have a lecture about this intermittent fasting because I have a study that goes along with the time restricted eating, basically eating only within an 8-hour window. But I can definitely say that it was a transition. Why? Because it helps with the appetite. And so the two are helping each other because the time restricted eating has been shown to reduce visceral fat more than a low carbohydrate diet. And so the two together is just so potent. But I did want to say thank you. I mean, this was the most informative lecture I think I've ever heard. And I mean, you're the master of this, and I aspire to speak this language as fluently as you. But I totally get it. I get it now with oxytocin. I got it before, but you put this stuff all together like this, and it's just, you know, it's mind blowing and really exciting.
It is. You know, I think the main thing, Dr. Joseph, is that it's all tied together by its role in pregnancy. If you look at every single thing that Dr. Halasa showed us tonight, they're all beneficial to basically what the body's doing is turning off the aging or delaying or retarding the natural aging process because it's accounting for the fact of pregnancy. I mean, that to me makes a lot of sense. I don't know if that's happening, but that would explain and tie together all these things. We had one interesting question in the chat, and Dr. Ortel, I was hoping you could comment for us as a gynecologist that has maybe got more experience with oxytocin than we do. And what I wanted to ask you is something out of the chat, which is that, you know, is it safe to give oxytocin to menstruating women who have an applicable condition? How would you feel about that, or would there be any reasons we shouldn't do that?
I would be concerned about the cramping. So you would want to make sure the person's not pregnant.
Well,
and
absolutely.
not going to get pregnant. And even not, you know, they may have cramps.
So you feel like the use of oxytocin, like when the lady would have her period, her menstrual cramps could be more extreme because there's more onboard oxytocin helping her uterus contract. Does that make sense? Is that correct?
Yes.
Okay. Well, that was an important question. I felt, thank you for that, because I lack experience in that area. I don't know what that would do. So, okay, great. Well, that's an important question to answer. Thank you for doing that.
Yeah, it's a very important question. Can we get a functional OBGYN on to get a lecture? I think that'd be fantastic to learn kind of holistic pregnancy care.
Well, the most qualified person here is Dr. Cheryl Ortel. Dr. Zeddy Berg is here, I think. She's here still. Those
Yeah.
are the gynecology we have here.
Yeah, if Dr. Berger's there, if you could comment a little bit too on if you feel like there's anything we should know from the gynecology perspective about oxytocin. Dr. Berger, if you happen to have any comments on that, when you come back, please feel free.
Hi. For so many years, we were looking for a hormone that would be a true anti-aging hormone. And right now, thanks to Dr. Halasa, who has done an incredible amount of research to put this lecture together, we have been able to hear what the possibilities are. So it is wonderful that now we have an option to another option to all the anti-aging therapeutics and methodologies we have used in the past. I unfortunately don't have any experience in the use of oxytocin. I think this has been a groundbreaking lecture for all of us. I don't know if anybody has any experience, but I'm really I'm really amazed of the possibilities we can achieve through the use of oxytocin. In the past, I used it extensively during labor and delivery for induction of labor. And that was the scope of the use of oxytocin. So I don't have any experience as an OBGYN in the field of anti-aging medicine using oxytocin. But this is, as I said, a groundbreaking experience. So we can take it from here.
Wow. Well, that's wonderful. That explains a lot, Dr. Berger, because you're right. It's that's kind of how I looked at it as well. Is like we already know what oxytocin does, but we didn't.
That's right.
We never, but you know, look at the long list of what Dr. Halasa has kind of brought us. Methylene blue, old drug, new tricks. Ivermectin, old dog, new tricks. Oxytocin, old dog, new tricks. You know, I think we've overlooked what a lot of these things do because we assume that we know everything already or that where there was no need to look further. But as you can see, the literature is there and it has been for a while, but there's been no need for people to look at it. You know what I mean? Like people weren't necessarily looking at it. And that's amazing, but I think it's commonplace.
I mean, looking for a hormone that would do all these, we used, I mean, it has been amazing to finally find this. We have been using growth hormone, right? With all the female hormones and testosterone, DHEA, everything included. And now we found this. I mean, how amazing. Yeah. So from now on, we have all these many possibilities of therapies.
You know, I just had a little epiphany speculation, but it makes me wonder if oxytocin has been needed so much in labor and delivery because perhaps the levels have been suppressed, with the women bearing children older, with all the autoimmune diseases and viruses that are suppressing the hypothalamus, that was the, if we didn't have that, we may not need oxytocin as much in labor and delivery. And, when it comes to, we'll treat a woman with oxytocin if she's 30 or 35, I think it sounds like we have to treat it kind of similar to the other peptides, where we use common sense. If they're over 40 and they're not thinking about having children, well, it's a no-brainer because it becomes like a bioidentical hormone, just becomes anti-aging. And I think, then there are some people who start on growth hormone releasing peptide, maybe for weight loss in their 30s. Well, it's probably their growth hormone is suppressed or declining too soon. And of course, we could use that same rationale with oxytocin. I think using discretion.
Well, the main reason we have used oxytocin during delivery is due to premature rupture of membranes. So we normally wait for 24 hours after the rupture to see whether that would stimulate the start of labor. And we watch very conservatively the health of the amniotic fluid, because chorioamnionitis is a common inducer of sepsis for both the neonate and the mother. So if the membranes rupture at any age and the baby needs to be delivered, the oxytocin has to be started, and that is a common practice in medicine. There is no other choice. I mean, if the patient doesn't respond to induction of labor through oxytocin, then she needs a C-section. But that is the main reason of use of oxytocin.
Gotcha.
Thank you.
Did you find any side effects with it? Like, I assume you used it in fairly high doses. Like, for example, did you find it to be sedate the patient, or did you find it had any effects on their blood pressure or anything that would cause you know that we should be maybe monitoring for here?
Well, certainly some patients were highly sensitive to oxytocin, and some patients were very insensitive. So the amount of oxytocin required per patient is something completely personal. Okay, the dose is standard when we start induction of labor, but the amount of oxytocin a patient will need, we never know. And yes, at the same time we start oxytocin, some patients have an increase of blood pressure during labor and delivery. And also those patients receive a considerable amount of IV fluids to keep her stable and the baby stable and the fetal heart rate stable. So we don't know if it is actually due to the volume of the dose of oxytocin or the volume of fluids, the cause of the high blood pressure. But as soon as the patient is delivered, the blood pressure usually drops down to normal.
Gotcha. I'm intrigued by your comment that people need largely different dosages, because I think that could well be true in this endeavor as well. And let me ask you a question or two there. One is, do you feel like that there is it known commonly that for example those who need a higher dose have a higher concentration of oxytocin receptors and sensitivity to oxytocin in the uterus? Or do you think that the oxytocin may be short or needed or used elsewhere in the body because there's an overall deficiency or something, and it doesn't have that much to do with the uterus?
I don't know. I don't know what is the answer. What I know is that during pregnancy, the amount of oxytocin receptors in the uterus increased considerably. Okay. And I don't think we have studied the presence of oxytocin receptors anywhere else. But something we watch for during labor is the presence of healthy contractions, and we try to prevent very intense contractions caused by oxytocin, because there is always the risk of uterine rupture, which is one of the greatest emergencies.
Well, when we do induction of labor, we give up to 40 international unit of oxytocin intramuscular, right? And
it is usually IV.
IV or yeah. So
it's IV. It's never IM.
Okay, so we get it up to 40 international units, so 10 to 40 international unit. That's inside the blood, right? What we're using in intranasal, it's 0.4 international unit per kg. You can say even one.
It is almost a homeopathic dose.
Right. So
what we're getting is 12 to 24 units. It's 12, yes. Guys, hold on, let's not get that wrong. It's 12 to 24 units. So it's about half of what would be used.
Yeah, but intranasal, what's getting in.
And you're getting a lot less. I agree with that.
But you got to get almost maybe 1%, 2% in.
At the beginning, when we start using the oxytocin on a patient who hasn't had any, we don't have any results, because I used the oxytocin intranasally a couple of weeks ago when I got it, and I had no results whatsoever. So it took me 3 days of using the one spray in each nostril twice a day to find that finally I had that sense of well-being.
That's right. I agree with you. I think
3
it takes
days.
about 3 days. I agree with that. 100%.
It takes 3 days
Yep.
then to produce the receptors, because it's oxytocin what causes the cells to change, and the receptors appear probably in 3 days.
Gotcha. So we need to recommend that people, well, this explains why it never worked in the past. I'll be honest with
It
you.
never worked in the past. I tried it for years. It never
Well, here's
worked.
why the same thing happened to me as you. People would call the pharmacy and they say, I have a patient who can't have an orgasm or has sexual dysfunction or whatever they were treating. And they would say, give them about 12 units, spray it once in the nostril before sex and tell me if you had the best sex of your life, and everyone failed, right? Well, that explains it, right? There was an insufficient dose, probably not a very well designed product, and then insufficient duration of treatment. And I agree with you 100%. I've used it myself, and I think it does take a few days till it begins to have a noticeable effect, and then you begin to really notice it.
Exactly. And then what I noticed is that the two sprays twice a day was probably excessive, because if I used it in the morning, I was fine all day, and then I didn't need the dose in the evening.
Right.
Because
And that's
I was well.
Right.
So I went down to 1 dose in the morning, but then I forgot. And for a few days I was feeling so well, why I need it. I'm not gonna use it if I don't need it. But then I really I really felt the effects of not having it. And it took me a couple of days of getting back into the rebound.
I had the same experience. I agree.
Let me add something, because I think we missed one of the thing it does, and I think Dr. Joseph James has one of the patients experience the same thing I experienced. I have a problem with sleeping at night because I have interstitial cystitis, so I wake up a lot and at night. And oxytocin is being used for treating interstitial cystitis because it helps to increase the vagus nerve and have it a sympathetic, and that helps to decrease the inflammation there. When I used oxytocin at night, and because of my disruptions of my sleep, because of interstitial cystitis, and could be also, I have other patients have sleep apnea, and there's studies about using it for sleep apnea. It helps to induce that deep sleep. And it's very important to have the deep sleep, because that's the only way we can detox the brain and get all the toxins of the brain out and be refreshed in the morning. So if somebody has problem with the insomnia, because it does increase the melatonin, by the way, and increase the melatonin is one of the mechanisms of oxytocin. There's synergy between both of them, oxytocin and melatonin. So I think people with insomnia, this will be a good management for them, natural thing, without the rebound or the side effects of all the sedative drugs. And I think Dr. Joseph James has one case who has a problem of sleeping for long years, and once he used oxytocin, he has this deep sleep, which will definitely help to refresh and prevent that brain fogging. Right, Dr. Joseph?
Correct.
Any questions?
And my whole thing this week in commenting is to, spread the message that, when I said it wasn't a sleeping pill, what I meant is more, if you take it in the morning, it's not going to make you sleepy. You know what I mean? It's almost like you go into balance. So whatever state you're in, everything is more efficient. So if you're trying to sleep, like I said, I've had a couple of nights, but for other reasons, I may not have gotten the best sleep. But when I do sleep, I sleep deeper. Okay, so that's another thing. It's not like an automatic, again, sleeping pill. It's just, it seems like it's improving all the functions, so that whatever you're doing, it's better, whatever you're doing.
Yeah, I have the same experience.
Okay, great. So I think we need to see if there's any questions, everybody here. Dr. Cruz, Dr. Claudia.
I actually have an online question here. We have a pain specialist asking, he says, if oxytocin is a mu agonist with no tolerance, how would we use that in chronic pain management with those who are already on an opiate, like, you know, OxyContin person or a buprenorphine person, you know, somebody who's basically has a painful condition, but also is kind of addicted to an opiate. How would we use oxytocin to their benefit, maybe?
Well, you start using it intranasal, and that helps to restore the mu receptor, because we know using opioids, it causes oxidative stress and down regulation of the mu receptors. So they need more of opioids, and because of antioxidant effect of the opioids. And that leads to neuroplastic changes and all the pain fibers, and you end up with hypergeusia. And they need more of those narcotics. And because of downregulation of the opioid receptors, then you need more of the narcotics because you need to produce dopamine, right? And dopamine is being released if you have those opioid neurons are active and increasing the dopamine. So because of the opioid receptors is downregulating because of oxidative stress, so you need to have more of narcotics. Oxytocin will help, same like CBD almost, helps to reverse all of that. It gives you the analgesic that you need because it stimulates the opioid receptor, but it is antioxidant, so it does not cause the downregulation of the mu receptors. And it also increases the dopamine release. And so you can you can wean patients from narcotics, and you don't have the withdrawal symptoms and the craving because the oxytocin will enhance the dopamine. So you don't have that shortage of the dopamine. At the same time, your mu receptors are building up, so you don't need that much of opioids. And that's how you can, so just go ahead and start the same dose that we are using. You can go up to 100 international unit a day if you want. It's in literature, it's the 40 international unit intranasal, but I think you can go up to 100 because we are giving IV 10 international unit to 40 international unit maximum IV, all the drugs. And when you do intranasal, you're not getting 1%.
It's about 4. It depends on the patient's technique or possibly the
it's 0.4 international unit per kg.
Right. And they're getting 4, it's about a 4% bioavailability estimated.
4%.
Yeah.
That is 4% of the pharmaceutical dose.
Right, I get it. Yeah.
So you're not getting that high, even for pregnant patients and patient with administration and contraction of the uterus. If you're just giving almost 4%, I don't think you're getting that enough of oxytocin that causes that significant contraction that leads to pain in the uterus or delivery. But we don't have evidence yet. So we tell those people with pregnant don't use it just because we don't have any studies to show that. But the reality is that those pregnant women, they have producing oxytocin, it's part of their system. And if they have low oxytocin and you give them intranasal oxytocin to replenish that, it's not going to be enough to cause the contraction of the uterus. So that's something me and Dr. Cheryl, we need to work on, and maybe who's now actively working on this and start, we need to use that on rat and mice and then use the humans to make sure. Yeah, for the uterus. We need to make sure that's the case. Just to be on the safe side, we will say, hey, just because we know oxytocin causes contraction of the uterus, don't use it until we have the studies to show that we're giving a dose that does not cause significant contraction of the uterus. And if we do that, that's something you need to study. So, and who's going to fund that? Nobody's going to fund it. Nobody is going to be doing it unless we build our own empire or field of medicine, board of chronic disease prevention management, and having funds to do those clinical trials, not to serve the pharmaceutical here, but here for the best interest of because those are repurposing drugs protocol, and nobody has interest to put money in it unless you have passionate billionaire like Elon Musk or somebody who's interested into the health of the people, then they will fund it, or a university who can be funded by the government. But all the government funds are really not that much comparing to pharmaceutical funding. Any other questions? And I would like to thank Dr. Ziti for all the compliment, and Dr. Joseph and all of you for the compliment. I'm learning from you guys. And we're learning from each other here, and we're trying to advance medicine based on our experience and skills, and hands-on on patients, and feed each other with all this information and learn from each other. And then we have the Blue Jenny, Dr. Mike Beamer, who is able to translate all this information into repurposing compounded formulations, so we can be ahead of the mainstream medicine protocols, and possibly translate what we're doing after we become successful to the mainstream medicine. But the only way that can happen is for us to have medical centers equivalent to Mayo Clinic and Johns Hopkins and all that. And we can do it if we work together, we team up, we join forces, and we think outside the box, and we think outside ourselves, and we have a mission and agenda for better of the humanity and the health of then we can have that purpose to drive us to do all the good work that we're doing.
Hey, Dr. Halasa, can I make a statement?
Yes, sure. And let me,
Can you-
before you make your statements, because you are from the military side, and oxytocin, just too much. It's hard for me to bring them all, but it does help post-traumatic stress syndrome, and it does help the brain injury, traumatic brain injury, TBI. So that is something you may carry it to your network of doctors and your vets, and have Dr. Bill Williams to treat those patients with oxytocin. And then go ahead, because I know that's something, it's your priority there.
True. Can I ask you to stop recording first, though, please?
Sure.
Okay, let's do that.
That's no problem. That's no problem.
There we go.